computer. So it is July 7th, 2021. It is Wednesday, and we are in kinesiology, and we are going to talk about special tests today. Ironically enough, it is also, for me, working in the gaming industry, it is Bungie Day. It's the day when the game industry producer Bungie calls their day that they release most of their games. That was when Halo was originally released, was on July 7th. So fun times, it's July 7th. So we're going to talk about the special tests and stuff like that. This is the part where people usually freak out because there's so much information. I'm going to tell you, you do not have to know all of this information for your tests for me. I will clarify what I want you to know for me, and then I will clarify why we're going over this, because you do need to know these for the boards. So I put 3 documents up. I put a PowerPoint up. I did a PDF version of that PowerPoint for John. And then I also put up a Word document with some stuff for special tests. And I'm going to bring that Word document up first. Let me bring that up here. So we have this magical Word document that freaks every single person who ever sees it out, because there are 5 pages of special tests on this Word document. And at that point, that usually causes fear, loathing, and nausea on somebody's parts. And what this document is I have gone through all of the special tests that you possibly could encounter as a PTA. So pretty much anything that's out there that's a oddball special test, I went through and found it. Just in case you should ever encounter it. A PT says something about, the Bonnell-Littler test, which I can't even tell you really what it is. If your PT says that, this sheet will tell you what that test is specially designed for. So a special test is designed to either rule in or rule out a condition. We're going to talk about that in the PowerPoint. But this slide, this Word document is designed to give you a quick snapshot of all of the special tests that are out there. I organized them by shoulder, elbow, hand, and then I went hip, knee, ankle, and went through all of them. There are a lot. Raquel's already kind of looking at them going, oh my God. What do you need to know for your boards? So the good news is you don't have to, we're going to talk about specificity and sensitivity in the PowerPoint. You don't have to know those numbers. You will need to understand those numbers for both my test and for the boards, and I'll explain those. I'll make it very simple for you. For the boards, you do need to know if they're talking about the supraspinatus test, or otherwise known as the empty can test, that is testing for supraspinatus impingement or pathology. If they talk about the speeds test, what is the speeds test for? So that is why I designed this little sheet that goes through a little 5 pages that goes through every single special test that exists out there. Now, there are by far more common tests that show up in the clinic and less common ones that show up. So a lot of the tests of the hands, like the Finkelstein, the Bonnell-Littler, the tight retinacular test, you're less likely to encounter those on your clinical rotation unless you're in a hand clinic. Whereas maybe ones of the ankle, you might not encounter if you're in a hand clinic, but if you're in a lower extremity specialized or orthopedic clinic, you might run into those. So I organized them by joint. Like I said, there is a lot of them. I am not, and I'm going to repeat this again, I am not making you memorize all of these tests. I am not making you memorize all of these tests. But it would be a good idea to print this off, hole punch it, and put it in your binder so that if you have a special test you don't understand, like maybe your PT does a scour test and you don't know what the scour test is. Well, that allows you to go and look up what that scour test is and how good of a test the scour test is. Here's a hint, not very good. Or the Patrick's test, or what's called Faber. And ironically enough, we learned that the Faber test is not a very good test at all. And we're going to talk about why those tests aren't so good in the on the actual PowerPoint itself. So yes, this is a lot of information here. And yes, I could go through every single one of these with you, but know that it's not what this is here for. This is here again. This is, I put this actually on your today's lecture, Anthony. along with the PDF for John, because John needs this PDF. I didn't make this into a PDF, John. You have to make your own PDF from the Word document. Sorry. I know I'm slacking. All right, so that's just there for your special. I have so many ways I could answer that. That's just there for that one. Now let me bring up the special tests. All right, so there is a lot in this PowerPoint as well. Special test for Special John, exactly. A lot of this PowerPoint is reproduced with permission from score builders, because your book, your kinesiology book, has a lot of your special tests in it, but it doesn't have all of them that I consider are decent special tests. So while that Word document has all of the special tests and what they do and how good they are, this has some of your more common ones you're going to encounter in the clinic and how to perform them. So the first thing we have to understand with special tests, and it ties to research information, is this term of specificity and sensitivity. And I think I went over this a little bit in why am I drawing a blank right now? Physics, there we go. My brain was not working. In physics. But this is the way you need to remember it for your boards, because they will ask you questions about this. And that is on spin and snout. So a test that has a high specificity, SP, if you get a positive result on that test, it helps you rule in a condition. So I'm going to use John as an example here. So I'm doing the Thomas test with John. And I don't remember what the specificity is on Thomas, but let's just say it's 98%. If I do the Thomas test on John and I get a positive result, meaning that it's saying that he definitely has a tight quad, a high specificity with a positive result means it is very likely John has a tight quad, or whatever that special test is saying. So I'm going to use 3 different tests up here, and we're just going to talk through them. So we have a specificity and a sensitivity. And they're going to be listed as decimals. 0.9, so we'll say it's test 1. Then we have our test 2. And then we have our test 3. So we have 3 different tests at the top of this lecture here that we're going to talk about. And again, they're not any specific tests at all. I'm just using these numbers as an example. So if I use test 1 on John and I get a positive result, because the specificity is high, 0.9 is a very high specificity. We ideally want above 75% or above a 0.75. Because that test is specifically high, and if I get a positive result, I can likely say John has whatever condition I have. Now, with test 1 here, the sensitivity is very low. For sensitivity, if you have a sensitive test that has a negative result, meaning that you don't get a whatever the test is testing for, it helps you rule out a diagnosis. But again, only if that specificity or sensitivity is above 0.75. So in this case here, we have a sensitivity of 0.36. That means if I test John and I get a negative with test 1, it really doesn't tell me anything. Because what a 0.36 says is if I have 10 people and 10 of them, I test, And out of those 10 that are negative, only 3 of those popped up as negative. So it's not a very good test for ruling out a condition. Test 1 is very good for ruling in a condition, but not good for ruling out a condition. Test 2 here, though, is not very good for ruling in a condition, but it's very good for ruling out a condition. In this case, right, John, so if I got a negative test with you, then I would want to do test 2 to definitely rule it out. You're correct. Right? Because I'd go, oh, well, okay, that doesn't really tell me much. Let's do another one and see if I can get a negative test again that's higher sensitivity and maybe get it ruled out, right? Ideally, the golden rule here would be to just do test 3. Because test 3 is both high specific and high sensitive. That's a great test. That means whether you're positive or negative, I can be pretty sure whatever you have. So, for example, the COVID test would be a great example of that. The COVID the nasal swab where they literally probe your brain. That has a high specificity of about 0.93 or 94, and the sensitivity is about a 0.89. I have 3 tests up here, Brooke. Test 1, test 2, and test 3, just as examples.
And that would say, like, if you did the Thomas test, that's Thomas 1, Thomas 2, Thomas 3?
Or it could be Thomas, Ely's, and something else. It's just 3 different tests.
Oh.
Yeah, I'm going to explain a little bit. So, John, let me answer that in a little second here. So 3 totally separate tests. So we'll call this test the Brooke test. This test is the John test. And this test is the Truman test. Now, let's say all of them are testing for if you have the flu. Let's just use that as an example. So I'm testing to see if you have the flu. So all of these tests are designed to test for the flu. We've got the Brooke Amazing test, the John Just Right test, and the Truman Terrific test, whatever we call them. Now, I don't know, I'm just making up as I go here, John. The thing about these tests, in the case of something like a flu test or a COVID test, it's a little different than the special tests we do in the clinic because most of those are going to have reagents, right? We're going to react something with that nasal swab to see if you have the test, right? But we're going to use this to explain this concept first. That's the only reason we're talking about a flu test right now. But we have 3 separate flu tests. You get that at least, Brooke. Does that make sense? 3 totally different flu tests.
Yes.
Okay, good. So now the whole class comes in because we're worried that we had an exposure to the flu. We have 3 different tests we can choose from. We can either choose the Brooke, the John, or the Truman test. Well, the Truman test looks really good, but because it's a high specificity and sensitivity, it probably is more expensive. Just because that's the way these type of tests work, right? So if we could just test everyone with the Truman test, that'd be great. But we probably can't. So we're stuck down to using a Brooke or a John test. If I test the whole class and I test them all with the Brooke test, and we test the whole class for it, because you're better anyway, right? We test the whole class with the Brooke test. Everyone that I get a positive test on the Brooke test, I can be very confident that they have the flu because Brooke's specificity on her test is 0.9. That means when we've tested somebody, if we've come up with somebody with a positive test, 9 out of 10 of those people that we tested positive actually had the flu. It's a pretty solid number. 9 out of 10 is really good in research. But let's say that we test it, right, and that's it. So let's say we test it, but half the class tests negative with the Brooke test. Well, because the sensitivity is not very high, we cannot tell, we couldn't tell Jason, Evelyn, Diana that they definitely don't have the flu. because the sensitivity is not high enough to indicate, yeah, you definitely don't have the flu. So what I could say is, well, then I'm going to do the John test on those people that tested negative. And when I test those people that are negative and they come back negative again with that John test, well, that's got a very high sensitivity, 0.99, right? That's literally saying 99 out of every 100 people that we tested that were negative actually were negative. They didn't have the flu. And so that allows us to, okay, yeah, you definitely don't have the flu. So we'd be able to clearly define who has the flu and who doesn't have the flu with those two tests. It's kind of like the two-step TB, yeah. Ideally, what we do is just bring everybody in and run the Truman test on everybody, because Truman's has a high specificity and high sensitivity. That literally means whether I get a positive test or a negative test, I can probably say you either have it or you don't have it. Like I said, the COVID test has a really high specificity and sensitivity. So specifically that one that they literally jam up into your brain. That one has a really good chance that if you test positive, you have COVID. If you test negative, you don't have COVID. The TB test is a test that is both, it's kind of specific, right? But it's more sensitive. So if you get a negative TB test, right? If you always ask that when they say, well, you get a negative TB test, right? So you're negative for TB. It is a very sensitive test, but it is not a very specific test, which is why if you get a positive on your TB test, you then usually have to go for a quantiferin test or a chest x-ray to make sure you don't have COVID. So it is not very specific. It is very sensitive. I think it's got like a 99.9% sensitivity. So 0.999. So it is a very good sensitive test. It just doesn't rule in conditions very well. The strep test. So anyone ever get the streptococcal test for strep throat? Does anyone know what you do with that?
Isn't it the swab in the throat, in the back of your throat?
Jab you in the back of your throat with the swab, like they jab your brain for COVID, right?
Yeah, terrible.
It is terrible, right? Because they swab that uvula and you vomit all over the place pretty much. And it's already sore and they just jab you in the back of the throat. If they scrape that and they do the test on it, that test is very specific, meaning if that test comes back positive, you have strep throat. If it comes back negative, you might have strep throat, but you might also have a fungal infection of the throat because it's not a very sensitive test. So a specific test will rule a condition in, a sensitive test will rule a condition out. If you have a test that maybe is for the shoulder and all you have is, it's very specific but not sensitive, it's very good to have two tests then set up so that you can both rule in and rule out the condition. And again, this is going to come more from a PT standpoint, but we have to understand why a PT is doing multiple tests. And the main reason is that specificity and sensitivity. So you need to get in your head this rule of spin and snout. So let me give like a example question here, what you might get if you were getting a quiz question or a test question from me. So let's say you get a question that says, and white is not going to show up, which of the following tests would be most effective at ruling in a given condition? Yes, well, it's just spin and snout are, okay, so I've got a lot of C's, and then I've got a D. Okay. So D would be numbers too. Yeah, you need to know the numbers. Well, you don't need to memorize the numbers. That's okay, Bianca. We literally just got started. We're talking about special tests. We're talking about spin and snout. That's okay. Let me, and Diana's lost, so we're gonna have to kind of rehash anyway. So don't feel too lost. I thought everyone knew that we were starting early. I went on. I'm gonna blame that on. Who can I blame that? I'm gonna blame that on Anthony because he told me. He said he all agreed.
I didn't know that we had to like think about the numbers too.
Yeah, you don't have to do any math with the numbers. You just have to be able to look at the numbers and translate them.
Okay.
Right. So here's the way. So I think Amanda was the only one that ruled D. Amanda, it's not a bad idea, but it's not the best idea. It's not the most effective at that point. The most effective at ruling in a condition would be the one that has the highest specificity. In that case, that would be C here. Now, that doesn't mean that D is a bad test. D would be a very, very good test at ruling both in and out a condition. But if I just am purely ruling in a condition, C is the best test for that. I'm going to try changing the color. Oh, I just went away. I just erased it all. Can I undo that? Oh, look, I can undo that. So when we're looking at these tests, test 1 and test 2 would be really good for ruling out conditions because they both have really high sensitivities. Test C here, so A and B are both good for ruling out a condition. Test C has the highest specificity, therefore it's the most effective at ruling in a condition. So again, the math is not so important, Diana. You don't have to necessarily be totally lost on the math of these. What you have to remember is that a good test is above a 75% or 0.75. So that means the test is a good test. And then you have to remember the rules of spin and snout. So a test that is very specific, has a high SP value, above 0.75 or close to 1 as possible. That is a positive, meaning I test Truman and he gets a positive test. It is good for ruling in a condition. If you get, yeah, okay, good. If you get a sensitive test and you get a negative result, it's good at ruling out a diagnosis. And that's why we're going to talk through a bunch of special tests today. So I'm going to use the boards as an example here. Anatomy is a very, very, very specific class for the boards. Meaning, if you did well in anatomy and you got a positive result in it, you'll have a high likelihood of passing your boards because there's a lot of anatomy on your boards. If you did poorly in anatomy, it's not as sensitive. So if you had a negative result in anatomy, it doesn't necessarily mean you're always going to fail your boards, but it's not a good indicator either way. So it can't tell you if you're going to pass or fail at that point. Right? So doing better at anatomy leads to a better final boards test. And a lot of the students that are out on the clinics right now are going, oh God, I wish I would have remembered my anatomy a lot more. So that's the concept of specificity and sensitivity. And I put on all of your, on that sheet, the Word document that I put up that has all of those special tests, I put the specificity and sensitivity of all the known tests I could find. And why did I do that? Well, that helps you when you know if your test is a good test or not. Some of the tests, you know, if you have a test, something like this, where the specificity is 0.5 by 4, and the sensitivity is 0.59. What does that tell you about that test? The test sucks. That's it. That's literally all it means. The test is a garbage test. You will find that some of the tests we do in physical therapy are exactly like that. And you'll ask a PT or a PTA, why are we still doing this test? And they'll go, same reason we do ultrasound at 1.8 watts per centimeter squared. Just because. Yes, John.
So when we do these tests, is it just like manual muscle testing, kind of like for the Yorkson's test, test for bicipital tendonitis? How would we perform that test?
We're actually going to come up to that in the next couple slides here.
Okay,
so some of them are similar to manual muscle tests, and then some of them are very specific. Like Finkelstein's and Phelan's are very different than a manual muscle test. So it just depends upon what they do. So good questions. That's a great question, Diana. So Diana asked, where do they document this under? Well, obviously, we're not going to document spin and snout at all, because that's just inherent in the test itself. But the PT initially is going to document what special tests they do under their evaluation. So they're going to say they performed, they performed the Brooke, the John, and the Truman tests at evaluation. And then when you see them later on in your kind of treatment, you are able to redo those tests to determine if you're getting a better result from them than maybe the PT got. Maybe 4 with the John test, they were really painful. I don't know. I'm just making one test up here as I go. But now you test them and they're not so painful anymore. Well, then we're going to perform the test under say that we performed Finkelstein's test with patient in seated. And then under the A, we would put what we found out with the test, right? Finkelstein test negative, improvement noted in nerve glides or something to that effect. We'll talk about the test in a little bit here. So then the other thing we have to understand about tests and research is this term intratester versus intratester. Intratester means within myself, intra, right? What I remember is intra has an A, that means alone. That means only you are doing the test. So Diana's treating a patient, and let's just use the manual muscle test as an example. She does the manual muscle test for shoulder flexion. She does it again. She gets the same results. That would mean she has a very, very high intratester validity and reliability, because everything she's doing is by the book and she's getting the same results. Intertester with an E, so inter, right? Interstate means going between states. Intertester means between 2 or more testers. So now if all of us did the manual muscle test for shoulder flexion on one patient and we all got similar results, that test would be very good intertester reliability and validity, because we've tested it. All of us got similar results. We all got a 4 out of 5 with our patient. That test is a very, very good test. If Diane, again, because she's the last one spoke, so she gets picked on a little bit here. If Diane tests a test and then tests it tomorrow and then tests it on Saturday and then tests it on Monday again and keeps getting the same results, that test states that it has very stable results. Therefore, it is a good test, retest option, meaning she's keeping to get the same results every time she tests it, whether it's today, tomorrow, next day. With test, retest, intertester, and intratester, we can then talk about validity versus reliability. Validity means, am I testing for what I'm supposed to be testing for? So let's say tomorrow I gave you your final exam. The final exam opens up. You open up the test, And the test is entirely on comic book characters. There's absolutely no physical therapy in it. I'm asking you the specifics, and not only like specifics about comic book characters, but like the minutia that only a comic book geek like me would know about the differences between the Jason Todd Robin and the Tim Drake Robin. Would that be a very valid test to give you guys? No, right? Because that's not testing anything I'm supposed to be testing on you guys. What that's doing is that's basically, I'm kind of giving you guys all the middle finger and giving you a test that maybe 1% of you might be able to get. You know, maybe Sydney's a secret DC comic book fan and I don't know it. And she passes that test with flying colors. But most of you will probably get it to go, I have no idea, C. That's what I'm going to pick for all these answers. God forbid I make it all fill in the blank. So that test would fail at not only validity, but specifically it would fail at face validity, meaning I'm not testing you what you should be testing. If a test would have content validity, like your boards that you're going to take have content validity. They have all the domains within physical therapy that you might actually treat under one test, right? There's cardiopulm, there's neuro, there's musculoskeletal, there's other systems, there's documentation, there's research. So when I have a content valid test, that means that it's covering all of the domains. Now, let's say I gave you your test tomorrow, and the test had nothing but manual muscle test questions. Would that test be, at looking at it, face valid? Would that still be testing kinesiology? Yes, it would still be testing kinesiology. Would that be content valid, though? No, right? Because we have goniometry as well and special tests. So that's how those two terms kind of work, content versus face validity, right? And then construct validity is if I make a logical argumentation that says, you know, if, again, I'm going to use the anatomy example. If you pass anatomy with a high test grade or a high score, you are likely to pass your boards. That is a logical argumentation. That is a theory. If I can back that theory up with research, that theory has good construct validity, and we can document that. One of the things we discussed on a call yesterday with the FSVPT is the results on your national boards are actually inversely proportional with the amount of time you spend in clinic. What does that mean? So the results on your board scores are actually inverse. What's that?
They're not related.
Yeah, they're not related at all, right? And what it's saying is literally the more time you spend in clinic, the worse you do on the boards. Versus the more time you spend in didactic classes, preferably in class, but this works as in class, the better you're going to do on your boards. There's actual research behind that. There is research behind how much time is the right amount of time, which is why we have specific requirements for your boards. You know, when you guys go out on your clinical affiliations, you guys are going out for 2 weeks, right? And then I think it's 8 and 8, if I remember correctly, or 7 and 7. I can't remember which off the top of my head, my brain. I think it's 8 and 8. The 8 times 40, I think it's 8 and 8, or 7 and 8. I don't remember. Anyway, one of those two. No, it's 7 weeks. 7 and 7. Thank you, John. When I went on my clinical affiliations, mine were 6, 12, and 12. So my first clinical affiliation was 6, and then I had a 12-weeker and a 12-weeker. By the board standards, what they're saying is you guys should score higher on your boards than I would score on my boards based upon my clinical affiliation. Now, there are other things on top of that as well, obviously, right? I'm just a genius, and, well, I'm sorry, there's only one of me. I'm just joking, kidding. But that would be a construct I could construct and test to see if it's valid. A criterion-related validity would be something where we design an idea and test it against a gold standard. The SATs are a gold standard for getting into what?
College.
College. Yeah, right? So what if I said the SATs are garbage and they don't reflect your scores in college? But the McKeever test over here 100% does indicate how well you'll do in college. I would have to compare those two tests and see if there is criterion-related validity between them, meaning does my test better than the gold standard? Right, so I'm going to do a concurrent validity test to see if I make criterion-related data. For example, in this case, concurrent validity is testing your manual heart rate versus what's happening on an EKG would also be concurrent validity testing. But if you look up here in the corner, this picture that I have up here, our tests can be very, very reliable, right? Here, right? I've got a very reliable gun in that picture. I'll talk about that in a second. Let me finish this thought real quick, Anthony, and then I'll cover that. Got a very reliable picture up here, really reliable gun, right? Because it's shooting in a good grouping. For those of you that have ever shot either arrows or guns, that's a good grouping, right? But that's not on bullseye. So it's not a very valid gun or arrow or bow or whatever I want to say. In this one here, I've got a valid, right? I'm hitting in here and I'm hitting what I need to hit. I'm hitting what I need to hit. I'm hitting what I need to hit. I'm hitting pretty close. But man, I'm all over the place. I am just haphazard everywhere. So it's not very reliable. In this one, I've only got really one that's in target and the rest of them are kind of up here. Okay, well, that's neither valid or reliable. If I'm hitting that target and I've got a good grouping, that means that my test is both valid and reliable. That is a gold standard test at that point. So a criterion related would be me comparing a score from a score from an SAT to a score from a new created test. That would be the criterion. And then I could compare the test itself against each other. That would be a concurrent validity. So you get a score from your SATs, right? I think it used to be on 1600. I don't know what the scores are now, but let's say it's still a 1600 because that's what I know, and that was back when I was ancient. If I'm able to show that my score on my test more closely relates to you getting into college and scoring better versus the criterion of the original test and scoring a 1600, then that means that I can say that my criterion-related validity over here is much better. The scoring of my system is much better than this. If you were to design a better physical therapy exam, Anthony, and say, look, this test is better than the MPTE. It definitely tests what PTAs need to know in the clinic, and I can prove it because here is this, and you prove the data. Or SAT versus an ACT would be another example. Exactly, John. Right? The SAT has been the gold standard forever, but then along came the ACT, right? And then to get into graduate school, we've got the GREs. So all of that comes into play. It does test for different things, right? But it also tests on a different scale, if that makes sense as well. So there's different scoring scale as well. No freaking that. Predictive validity and prescriptive validity talk about predicting future events. A predictive validity successfully predicts future events. A prescriptive validity prescribes treatments we should follow. So we typically follow a prescriptive validity pattern in physical therapy because we say, if we do these things, patients should get better. If we follow this treatment plan, patients should get better, right? That's kind of the way we do most things, or we should do most things. And again, reliability is just the consistency of research. Are we testing what we're supposed to test? I know that was a lot of statistics, and we're going to hit these again in 5th semester. But what I need you to understand is just the basics of these. So the definition, understand spin and snout. Understand these definitions and be able to pick the definitions if I give you a test question about them. If I give you a test question about criterion versus concurrent validity, be able to say that criterion is comparing the established data of a gold standard versus comparing the test itself, concurrent validity, to a gold standard. And why do we do all that? Well, because of all of these special tests. Right? And what these special tests do is allow us to go through. So Diana says, lecture in the final exam. Some of the definitions are, you're not going to have to know every single special test. If I repeat a special test multiple times, that's probably a good one to know, especially for the clinic. So these are the more common special tests you're going to run into. I will say the speeds and the Yorkson's test are probably two of the common ones you're going to have to do in the clinic, along with supraspinatus. We actually already did or talked about the Adsons, and we performed the Roos test already, right? Those are thoracic outlet. The Roos was the one where you did the little, and for 2 days my hands were hurting. Go forward. You're not going forward. In the elbow, I'm going to say this. The only one that I've done on a regular basis in the elbow is Tinel's sign. And Tinel's sign is just a tapping on the nerves. So that's where you're going to go back on that nerve in the funny bone and tap on it. That can be done at many places. That can be done at the elbow. That can be done at the wrist. That can be done here on the canal Keon. Tinel is just a tapping sign in the elbow. I don't remember the last time I've done any of these tests. I just don't. I don't see a lot of elbows, so I can't tell you the last time I've done one of them. At the wrist hand, I have done the Allen test, and you guys have already done the capillary refill test before, right? That's where you press down, you watch it fill back up. Capillary refill test can be done on the fingers by pressing them together and counting how long it takes for your finger to return to normal color. Dr. Vreskin is going to go over Frommets, Phelan's, and Tinel's. We're going to talk about it as well as Finkelstein's. We're going to talk about it quickly, but she is definitely going to hit those next semester in hand therapy. In the hip, the major ones in the hip are the Thomas, the Ober, and probably the Elis, or the Elis, depending upon who you ask. Those are your major ones for the hip. We talked about Trendelenburg. That's more for gait than it is anything. That's where you pick up the pelvis and it drops. That indicates they have a Trendelenburg sign. It's not really a special test per se. In the knee, the most common ones are the anterior drawer, the posterior drawer test. That's testing for ACL and PCL problems. McMurray's is a close third, but even that I don't do as much because an MRI is a little bit better than McMurray's for telling me if I've got a torn meniscus. At the ankle, the only two that I can think of that I've done are these two, the Homans and the Thompson test. We're going to talk about this. I think this is more the hip than it is the ankle, but just because it ends down at the ankle, they call it an ankle test. So as you can see, these are the ones that they say you definitely have to know for your boards. That list of tests is a lot shorter than that huge honking list I gave you, right? But I wanted to make sure you had all of the tests in case you encounter them out there. So let's just talk about a few of them. So we're going to talk about the arm first. Do some bicep curls here. So the apprehension test, you guys have seen that picture, right? Patient's positioned supine with the arm in 90 degrees of abduction, and then you externally rotate the shoulder. If the patient goes like this, meaning they look like they're in pain. That means they are in apprehension, which is fear. They don't want to go out there because they feel like their shoulder is unstable. Again, not a very big test, not one that I encounter on a regular basis, but it's out there. So this is kind of doing that apprehension test. Posterior dislocation is where the patient's position is supine, with the arm at 90 degrees flexion and medial rotation, right? So here and here. Therapist applies posterior force. I've never done this test ever, because posterior dislocation just doesn't happen as often. Anterior is more common. But most of the cases, if you have a question about apprehension, it's asking, does the patient look like, it hurts? Apprehension means pain or scared. Speeds. Patient is positioned in sitting or standing with the elbow extended and the forearm supinated. Therapist place one hand over the bicipital groove and the other hand on the volar surface of the forearm. You go up into shoulder flexion. So I'm going to put one arm out here on this, and I'm going to go up into shoulder flexion. If I complain about pain up here in the bicipital groove, that means I have typically bicipital tenosynovitis or tendinitis. So what I'm doing is literally doing a resisted shoulder flexion activity with the arm in supination to kind of isolate more of the bicep part of the shoulder flexion. And we're seeing if that tendon pops up and out of the groove. This lady looks so thrilled to be doing this test. Just the best picture in the world. Yorkson, by far, to me, is the better test. I do this more frequently than I do the speeds. Patient's position is sitting with 90 degrees of elbow flexion and the forearm pronated. Humerus is stabilized against the patient's thorax. The therapist places one hand on the patient's forearm, the other over the bicipital groove. And then the patient is asked to actively supinate against resistance. So I'm going like this. Tilt the camera down some. That didn't work out. There we go. So the patient's going to be asked to actively supinate against resistance. Again, positive is going to be indicated. These are the ones that you need to know for the boards. Yes. Right? And also, these are the ones you're probably going to encounter in the clinic as well, Amanda. These are the more common ones you're going to encounter in the clinic. Less common for you to encounter the Clunk test than the Yorksons. Drop arm test and the Hawkins-Kennedy impingement test. Less common to encounter it. We'll have a lab on the more common ones. Yes, John. Less common to encounter these, more common to encounter this test here, the supraspinatus or the empty can test. Patient's position with the arm in 90 degrees of abduction, followed by 30 degrees of horizontal adduction with the thumb pointing downward. The therapist then resists the patient abducting the arm, pulling it back up. We're testing pure supraspinatus at that point. So it's probably all of you have seen the empty can test, or most of you that have been in the clinic have seen somebody doing the empty can test, yes? Or the empty can exercises, right? That's one that we're looking to see if there's supraspinatus tendon tear, if it's impinged at the AC joint, or if there's subscapular nerve involvement. So all of those, if I get a positive, patient's like, ow! Like if you do that with my right side, that actually does kind of hurt because I've got impingement in the right shoulder. That one is definitely one, if I'm a person going to an outpatient clinic, I better know that test. Adson was the one that we were testing for thoracic outlet syndrome, specifically the blood flow of the thoracic outlet, right? That was the one where you have the patient, you check their radial pulse, right? And then you have them rotate the head to the test shoulder and then extend his head while the therapist laterally rotates and extends the patient's shoulder. So they go back like that. And you see if the pulse vanishes. More common in a hand therapy clinic or a shoulder clinic than your traditional outpatient clinic. But let's say that John is working with a patient that has shoulder problems, and he's starting to suspect the shoulder problems aren't shoulder problems. They're actually brachial plexus problems or thoracic outlet. This would be a good thing to maybe say to the PT, hey, can we like try an Adson's or a Ruse to see if maybe the problem is not the shoulder itself, that it's the nerves going to the shoulder. Allen's is very similar, it just changes the head position. So Allen's and Adson's are very similar, it's monitoring blood pressure. And then the Ruse is the one we did like this, right? Where we sat and did this for 3 minutes, right? And we did this, open, close, 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 close. And a positive test is either while they're doing it, they just put their arms down, right? You get numbness or weakness while they're doing it, or you get ischemic pain. Because you're doing this for so long, the blood flow gets cut off and your fingers like turn white or black and you have ischemic pain, right? Almost like the intermittent claudication of the legs. Varus and valgus stress test of the elbow is exactly like varus and valgus stress test of the knee. You're just putting a pressure either laterally on the knee or medially on the knee to see if they exhibit pain. It's just testing how strong those medial or those lateral collateral ligaments are, right? That's kind of the idea. So a varus test, test your LCL. A valgus test, test your MCL. Varus versus valgus. And again, like I said, the elbow test, I can't say I've ever done these. This one here, I think is mean. I've done this once. So this is where a patient puts his thumb on the patient's lateral epicondyle while stabilizing the elbow joint. So I tend to do it with my fingers. Lateral epicondyle will stabilize in the elbow joint. Patient is then asked to make a fist, pronate the forearm, radially deviate, and extend the wrist against resistance. So you have to resist them as they come up. And if the patient goes, ow, they have lateral epicondylitis. What I'd like to see is who doesn't say ow to that test. Like, it's funny, I had asked an OT about that, and they're like, yeah, everyone that I do Cosen's on says they have pain at the lateral epicondyle. Right, it just hurts to press on the epicondyles, right, Riley? You're like, right? So is that a very good specific test, right? Probably is very sensitive. I'd be willing to bet if you don't get pain there, you probably don't have epicondylitis, right? What it probably tells me, Riley, is we've all got a little bit of epicondylitis, right? That's kind of where I'm at with it, is we all have a little bit of epicondylitis, right? So that was kind of testing there for, we've got that, and we got another lateral epicondylitis test, which isn't that different from that one. The medial epicondylitis test, same idea. We just test on the medial epicondyle. Tenell's. Again, Tenell's is one that's going to be at the wrist and the elbow, where you're going to take your index finger and you're going to tap it. You're going to find that back there where that nerve passes through, right, the ulnar distribution, and you're going to tap on that nerve spot. I'm specifically doing it on my left arm so that my hand doesn't go numb, right? And you're tapping. If you tap it and the nerve goes numb, or you get some tingling and feeling down the hands, probably got some compression on that nerve. We can also do that for the median nerve. I can come down here and tap on the median nerve. And if I get tingling and stuff like that, it means there's some compression in that median nerve. So Tenell's is not just of the elbow. Tenell's is pretty much for any nerve. I can even technically, if I come up here and tap on the brachial plexus, and I get burning and tingling going down the arm, that's technically a Tenell's of the brachial plexus. Ulnar collateral and another Allen test. I'm going to say for these both, don't really worry about them. I don't think I've encountered them. This Allen is just another vascular insufficiency test for thoracic outlet. This one can be fun, the Allen. I did forget about this. The Allen test can be kind of fun because what you're going to do is you're going to compress the radial and ulnar arteries. So you can do this on yourself if you take 2 fingers, put it on either side of your wrist and find those pressure for where you get those arteries kind of pumping in there, and you press down, right? So you squeeze the hand and then you press down on those arteries, right? And then patient opens the hand and you let go and you watch the finger color return to your hands. So watch as I do this. So I'm gonna get it nice and tight. I'm gonna press down. I've got those arteries occluded. Look at the color of my fingers right now. They're kind of white, right? Now watch the magic as I let go. It's magic, right? It's a cool trick. That is cool, right, Oscar? It's a little trick that you can show your family. Like, let me see your wrist. And you kind of press down on those. So you have them close their fist, press down on those arteries, and then have them open it. And their fingers should be kind of white. And then you let off, and the fingers will return back to normal color. It should take, I want to say it's the positive test is within, I think it's 10 seconds. So actually doesn't even say it. Pretty confident that the positive test is supposed to be if it doesn't return in 10 seconds, but it doesn't say it, just saying here it's delayed or absent flushing. So if one hand side takes longer than the other side, then that's when we're looking at that they might have a constriction in one of those blood vessels. But I think that's a cool magic trick to me, right? Right? It's very much like capillary refill, except for it's a whole hand, right? Look, my fingers are white. The more I press, the whiter my fingers get, and then back to red. It's a cool magic trick. You guys are gonna be doing that. Capillary refill test, here it is. It does say, so it says refill time should be about less than 2 seconds. So again, take your finger, press down on your finger, hold down for, doesn't even say, I usually hold for about 5 seconds, let off, and then time how long it takes to return back to normal color. If it's 2 seconds or less, you're normal. If it takes longer than 2 seconds, could mean that your blood flow is compromised. Most of the times that I've encountered that with the patient, the main thing that's problematic is they're dehydrated because the blood just doesn't flow as smoothly when they've got sludge in their veins. Fromets is a fun one. Fromets I talked about briefly already. Fromets, the patient is asked to take a piece of paper, right? Hold a piece of paper between the thumb and the index finger. So kind of like this, I'm holding it here. And then once they're holding it there, right, the therapist pulls it away. So if I'm holding it here like this, right, positive test is if I flex that digital phalanx to hold it. So I'm supposed to keep everything nice and straight. So if I do that on my left side, I automatically start flexing that distal phalanx because I know I'm weak on that side. If I just let it go, I don't have the strength to resist the pull. Can be indicative of nerve compression, can be indicative of all kinds of things as well. So it's just kind of looking at that from it. Sign. Phalans, this is one that nobody likes. All right, so phalans, patient's position is sitting or standing. The therapist flex the patient's wrist maximally and ask the patient to hold this position for 60 seconds. So we're gonna do this one. So everyone take out, we're gonna do it together. I'm gonna put a timer up. Get my little timer up here. So you're gonna be sitting, I don't think I got a picture of it. So there's what you're kind of looking like. A positive sign is if you get numbness or tingling down the first 3 digits. So we're gonna take our hands, put it back to back like this in a reverse prayer position, get in that position, and we're gonna start it. We're gonna hold that for 60 seconds. I dream a genie. So hold it. There's 15 seconds for you. Anyone getting numbness or tingling yet? Can't type. Oh, that's right. You're doing the thing for me. If you type, then you're not trying. I tricked you. Oh, there goes my thumb. 40 seconds. Starting to go out my index finger now, my right hand. You guys got 6 more seconds. You can do this. 5, 4, 3, 2, 1, and then you come off. And it should take a little bit, but the sensation will go back to normal in that hand. Did anyone get, so Raquel, did you get any numbness or tingling with that? Better than the ruse. Brooke, your bicep hurt. That's interesting. Probably from the positioning. You're probably tight.
I got numbness
Jason,
and
what's up?
tingling. I got numbness and tingling in my left thumb and left index finger.
Oh, hold on, my headset's dead. Or off. Let's try that again. Now my headset's on, I can hear you.
Or I got, well, actually not numbness. I got tingling in my left thumb and left index finger.
Yep, that means that you got a little bit of compression in that carpal tunnel, right? Numbness in the thumb, Diana says, right? And so what does that mean? Does that mean you're broken? Well, maybe. Just saying. Okay, lateral part of your elbow hurt. Well, that kind of makes sense. Why would the lateral part of Bianca's elbow hurt?
Ulnar nerve compression.
Okay, could be ulnar nerve compression. What else could it be? Think of what I've done here. What's on pretty tough stretch at that point? All of those extensors, right? Yeah. Right, so she's probably got some tightness out there. Right? Too much time. Are you a server by chance, Bianca? Or have you been a server before?
I have been, yeah, in the past. Not currently, but I have in the past.
Right? Carrying a tray, think about it.
Yeah.
Right? That's where you put back an extension. Ah, see? And that also then compresses the carpal tunnel and you could end up like Diana and Jason then eventually. So, that would be one where we're like, okay, we've got a positive test. What does it mean? Well, it means that you could have a nerve compression, so we need to treat it, right? We're going to stretch out that carpal tunnel, try not to send them for surgery. This guy always looks like, he's like the Bruce Lee of physical therapy to me. I don't know why. It's like, anyone else see that? Am I the only one that sees the Bruce Lee of physical therapy there? Okay, fine. I'm the only one that sees it. Finkelstein's patient is positioned in sitting or standing is asked to make a fist with a thumb. So we're going to try this one. So you're going to take your thumb and you're going to tuck it into your hand. You're going to curl your other fingers over it. And then once you're in this position, ulnar deviate your wrist. And let me know if you get any pain along this part of your hand. Riley's like, ow. Oh, I've done this before, right? I'm doing it, like, it's uncomfortable, right? The good news is I've got nothing in that left hand, but that right hand, man, whew. So that's a good sign that you might have a little bit of deep veins in that thumb. Jason's like, yep, you're just broken, Jason, I'm just saying. And Oscar's like, yes, I'm positive for, I'm negative for something for once. And John, probably is because you're probably more right-handed, I'm assuming. Right? So all that means is, right, we got to make sure that we take care of that thumb a little bit and stretch it a little bit. I know I get mine. Why do I get mine? Because, last night, Mr. McKeever might have gotten a little bit of a Destiny session in, and I played a little bit too long last night. I look a little tired. There's kind of what Finkelstein's look like. In that case, the therapist is doing it, but most of the time we have the patients do it. I always like this because we're talking about the lower extremity now. Told the doctor I broke my leg in 2 places. Told me to stop visiting those places. No? Okay, John got it. So Ely's or Eli's test, and this is one that I would say that if you're going to an outpatient clinic is a pretty good one to understand at least. This is checking to see if we get some sort of a rectus femoris contracture or the rectus femoris is tight. Patient's position in prone while the therapist passively flexes the patient's knee. If you flex that knee and the other hip picks up, That's a positive Eli test. I think we've got a picture of it here. So as we're sitting here, I'm going to bend that patient's knee up into flexion. And if when I bend that knee up into flexion, the patient does this, what they're trying to do is shorten that rectus femoris because it's tight. A lot of you are probably going to have that happen. When we do the Thomas test and do this one, we're going to find out we got a lot of people with tight quads. That also then, if I wanted to stretch out that rectus femoris, could I just turn this into a stretch?
Yeah.
Yeah, right? Because now as a therapist, I could push down on that patient's pelvis, right? And then slowly bring it up until I get to that tightness and turn it into a stretch. Yeah, right? Tests are also performed on kids. Yeah. Eli's a lot, and we're going to talk about the not homins, but the Thomas. I'm drawing a blank on the one that I'm talking about. It's for the calf tightness. It's just, for some reason, it's escaping me right now. We'll talk about it in a second, Diana, for sure. But yeah, that's one we'll definitely have a positive for a few of you. This is another one we're going to have a positive. The way I remember the over test is for TFL tightness. I always say that in order to do the over test, you got to throw the leg over the other leg. Get it over the other leg. You're going to throw it up and drop it over. Patient's position side lying with the lower leg flexed at the hip and the knee. Therapist moves the test leg into hip extension and abduction, and then attempts to slowly lower the test leg. Positive test is inability to lower the leg. So this is where we're going to find out if you've got a tight TFL. And I'd be willing to bet we're probably going to find a bunch of you guys that have tight TFLs as well. Yeah, a lot of people do. We don't even realize it. And then if you do have a tight TFL, it's not uncommon, especially if you're a runner, to get pain out here in this lateral aspect of the knee. And so sometimes if you just stretch that TFL out or roll it out, a lot of times that'll relieve that pain out there. Piriformis, this is what I call the test that you do if you hate your patient. Patient's position is side lying, test leg position towards the ceiling, hip flex 60 degrees. Therapist puts one hand on the patient's pelvis, the other on the patient's knee. While stabilizing the pelvis, the patient applies a downward adduction force on the knee. If the patient goes out, the piriformis is tight. There's not a good picture of this one. I've got a good video that I'll show when we do this one. So, but basically, patient's going to be positioned side lying, one leg up like this, right? Therapist put one knee on the pelvis, the other on the knee, and you're going to push down. And when you push down an adduction force, it's going to stretch out that piriformis. And if it's really tight, the patient will go, ow, or hey, the back of my leg is burning because sciatic's now being pinched down on. Not as common as something like the Ober test, but it's out there. I'd say that the Ober and the Elis are probably two ones definitely to know. And then this one, the Thomas, right? So Thomas test is where you have the patient lie on their back, grab a hold of one of their knee, and pull it up to do a single knee to chest. If the patient is able to lift their one knee to chest and their other knee leg doesn't raise off the table, they don't have a positive Thomas test. But if when they pull that leg up, the other leg comes up with it, and I can actually sit here in the chair, pull this knee up to my chest, and I can feel my other leg starting to come up with it. That kind of tells me I've got tight quads. Because what's happening is the whole pelvis is moving with it. And the pelvis is trying to avoid really irritating that other quad, right? So now, if I pull my right knee to my chest and I get a positive Thomas test, which quad is tight? The left. Good. Right? Because what's happening is this one's coming up with it. So it's this quad that's not able to stay down. And again, this is another one that it's a special test, but I can turn it right into a stretch. Because what I can do then is put my hand up here on this patient's knee. Actually, what I'd have him do is I'd slide his butt down here. Put my hand on this knee, and then I'm going to push down with that leg kind of dangling off the mat to stretch out that quad and let it hang. Yep, exactly. Or I'm going to be mean. I'm going to push because I'm the mean therapist. Nobody likes me. Right. Yeah, they're good for stretching. Exactly. Tripod sawing. Yeah. Can't say I've ever done this one. This is for tightness in the hamstrings. I've done the 90-90 straight leg test, but the tripod sawing, never really have done. This patient's position is and sitting, with knees flexed to 90 degrees over the edge of the table. Therapist then extends one knee. Positive test is indicated by tightness in the hamstrings. Well, we all have tight hamstrings. 90-90 straight leg test typically is a common one. So patients asked position supine, asked to stabilize hips in 90 degrees of flexion with the knees relaxed. Therapist then instructs the patient to extend a knee. If the patient can't fully extend the knee, that tells you that the patient has tight hamstrings. I think this picture has, no, it doesn't. So what you're saying here is, here I am laying on the mat. I'm going to flex my knee leg to 90 degrees like this, my hip. And then the therapist is going to tell me, extend your knee, and my knee should be straight up and down. Yeah, like Anthony says, I think we all fail at the 90-90, right? If you have a 20 degree, so if this degree here is 20 or greater, that means you have a positive hamstring, right? Honestly, the tripod sign's enough, even though I've never done it. I can sit here at the chair and kick out with that leg and know that I'm not able to fully straighten that leg. Go, oh yeah, I got tight hammies. Craig's is to test for femoral anteversion. So this is looking at whether you are anteverted or retroverted at the feet. Again, I'm going to say this, it's good to know for the boards, but not as common done in the clinic. So we're going to position them in prone with the test knee flexed to 90 degrees. Therapist is going to palpate the posterior aspect of the greater troch and medially and laterally rotate the hip. The degree of femoral anteversion corresponds to the angle formed by the lower leg with perpendicular access to the table. What? Wait, what? What, Mr. McKeever? Well, this is kind of what we're doing here. But again, yeah, I've done this with kids in order to prevent them from becoming too anteverted or retroverted. But I think if I remember correctly on the sheet that I gave, this doesn't have a really high specificity or sensitivity test in the test. Faber's is testing iliopsoas, sacroiliac, or hip joint abnormalities. This is just one where you put the patient in supine, test leg flexed, abducted, and laterally rotated. So you're going to have the leg across. And then the therapist slowly lowers the test leg through adduction toward the table. If the patient drops it, right, or can't maintain a nice steady pattern, it could be an indicative of poor iliopsoas test. I've also seen this called the drop leg test to go along with the drop arm test. But yeah, again, not a big one. Trendelenburg we talked about. Have the patient pick up one leg, watch, see if that contralateral hip drops. If it does, we know we've got a positive Trendelenburg sign. And if I pick up my right leg and it drops, which hip is affected?
The left.
Left, good. Yes. Right, it's always the contralateral hip. Good. See, you guys did learn something. Feel proud. Anterior drawer test. I am going to let all of you do the anterior drawer test on me on my left leg, just so that you can feel what a positive anterior drawer test feels like. Because I think I didn't understand a positive anterior and posterior drawer test until I felt one for real. And mine is definitely one that you go, okay, that's what it's not supposed to feel like. So anterior drawer test is for ACL integrity. Posterior drawer test is for PCL integrity. You're going to put, you both are going to have the same position. Patient's going to be supine, knee flexed to about 90 degrees, and the hip flexed to about 45. You typically sit on their foot while it's on the mat. You grab a hold of their tibia, right? So you get a nice firm grip on the tibia. And if you're doing the anterior drawer test, you pull it forward towards you. If you're doing the posterior drawer test, you push it back away from you. For the most part, you should have a very nice, firm end feel with very little movement if the ligaments are intact. With me, what you'll feel is you'll pull forward and you'll feel that tibia just kind of shifting the whole way. You're like, oh, look, I can go 2 to 3 inches forward. It doesn't hurt, doesn't bother me at all. But it's because I have no ACL in my left knee. So I always find that if you experience what a positive drawer test feels like, the next time you encounter one, you'll know. Because some people are like, is that positive? Or is he just really kind of loosey-goosey? Like, we may test Diana's knee, and she may have a little bit of give with it. But it could also just be that she's got a nice, you know, limber knee. And she's, you know, she's not as tight as other people, right? Or we may test Truman, and we get a hold of his knee, and his knee doesn't move anywhere because his ACL and PCL are just locked, for all we know. Because he's now not skipping leg day to show us all off, show us all up. So this is kind of what it looks like. That guy's doing an anterior drawer test, pulling it, but again, a posterior drawer test. So anterior drawer, I'm going to pull it that way. Posterior drawer, I'm going to push it that way. Ironically enough, for a varus and valgus of the knee, the only difference is either pushing in or pushing out. So they're not all that different in testing positions. Lockman's. Yep, go ahead.
Sorry. If you have a hyperextended knee, would that be any different with the test result or no?
Nope, not really.
Okay.
Yeah, because
Okay.
remember, hyperextended knee is more about that patellar tendon than it is anything.
Okay.
So yeah, I mean, maybe you might have a little bit of laxity in your ACL, but not too much.
Oh, okay.
Yep. Lockman's tests for ACL injury as well, but Lockman's just puts it in a different position. So now you're at 20-30 instead of that 90. Not really that big of a difference there with Lockman's, to be 100% honest. So now I'm down here and I'm pulling. I don't like Lockman's because I find that they're in less, right? I find that they're in less of an open pack position in this position. So I don't get as much motion if I've truly got a patient. I tend to like the anterior and posterior drawer tests. But there are a lot of therapists that prefer Lockman's. Lateral pivot checks for anterolateral instability, so any rotation or a clunking in the femur. So this one's kind of weird. Patient position is supine, hip flexed, abducted to 30 degrees with slight medial rotation. Therapist grasps the leg with one hand and places the other hand over the lateral anterior surface of the proximal tibia, and then medially rotates the tibia and applies a valgus force. Again, these are going to be mean tests if your patient has these problems. If there's a clunk, this is also known as the clunk test of the knee. If there's a clunk where it's like clunk when you're rotating that tibia, then we've got a positive test. And at that point, they've got some instability of that tibia on the femur. Posterior drawer and posterior sag. Again, posterior drawer, you're pushing backwards. Posterior sags exactly like it sounds. Rather than pushing, you just let gravity do it. So you put them in a position where the leg can just kind of sag back, and you watch to see if that tibia drifts backwards. Valgus and varus, I told you already, just going to push either way. The compression test, either McMurray's or Apley's, are tests for meniscal pain. So what you need to know about this one for not only for your boards, but also for your clinics, if the patient has a positive Apley's, not Epley's, Apley's, or a positive McMurray's, they have a tear in their meniscus of the knee. That's really all you need to know. Again, you don't necessarily need to know the positioning for this one, but you need to know that both Apley's and McMurray's are for tears of the menisci of the knee. The brush and patellar tap test are just for swelling. That's it. That's all they're there for. And again, in the clinic, I've never done them. I've known clinicians that have done them with patients that have lymphedema and stuff like that. But I can't say that I've ever done them. And I, like Dr. Vreskin said, she's done the brush test like once because I talked to her about this. So not a very common test. With the ankle now moving down, anterior drawer test of the ankle is exactly like anterior drawer test of the knee. You're going to get a hold of that talus and the ankle mortise and try to separate them by pulling forward. If you have movement, that anterior talofibular ligament is strained or injured or torn. Talar tilt just looks at the tilt of the talus on the actual calcaneus. Yeah, I'm going to talk about that towards the end here, Diana, for sure. So Diana asked how the boards phrase it. So I'm going to kind of go over it. Homans, if you see a positive Homans test, what does that mean you should do therapy-wise?
Tell them to go get an ultrasound.
Yes, right? If they're in the hospital, we wave off and stop therapy. Good, right? Until we get a cleared ultrasound. So nurse comes in and goes, oh, yeah, they've got a positive Homans, but he's okay. Go ahead and get him up. Run away. Run away fast, Bianca. Because, again, you have a positive Homans, they may have a chance of having that blood clot, and you get them up and you can kill them. So for your boards, don't have to know how to do Homans. You have to know what you're testing for blood clots of the calves. But the main idea here is, yeah, PT is not supposed to move for a while. Patient or the patient should not move for a while until they get cleared. Usually they're going to be on bed rest until they get that Doppler ultrasound of the calf. Because again, if I'm pressing down and they've got a ton of pain between those gastroc heads, it's a pretty good sign they've got a blood clot hiding in there. Now, all of us, if I push down between my gastroc heads, it doesn't feel good. Like it's not, I don't like it, right? It doesn't feel good, right? Riley's probably going, yeah, it doesn't feel good at all either. But that doesn't mean I have a blood clot. If you have a patient where you push down between those gastroc heads and slightly dorsiflex the foot, they will literally just about jump out of their bed. It hurts that bad. That's when we go, you might have a blood clot there, buddy. Let's get you checked out. Always better to be safe than sorry. I'm just saying, you can always get a negative ultrasound and the patient doesn't die. But if the patient dies, well, that ultrasound's not going to help you any at that point. Yeah, ultrasound a dead patient. This was it, the Thompsons. I couldn't think of the test I was trying to talk about the calves. This one I do a lot with kids, Diana. This is one that I do spend a lot of time with kids because a lot of what I work with kids is tight gastrocs, those kids that walk on their toes, right? What kind of gait is that again, walking on your toes?
Yes, yes.
What's that? I heard somebody say something. I think they backed off. They're like, maybe not.
Is it gastroc gait?
It's gastroc gait. Okay, that's one of them, right? The one that sounds like a horse. That's not the horse's tail.
Waddling?
Oh, what's the term for horse again? If you ride a horse, you are a equestrian.
Equestrian, yeah.
Yeah.
So equine gait.
Equine gait. There you go. Good. Yeah. Equine gait's where those kids walk up on their tippy toes, right, when they shouldn't. So I do a Thompson test a lot on those patients. That's okay. That's why we're doing this treatment. See, it's kind of cowboy. That's the waddling gait, John. Cowboy gait's the waddling gait. Thompson test, I'm going to put the patient in prone with feet extended over the edge of the table. The therapist is then going to ask the patient to relax. and squeeze the gastroc. I'm going to try to get around the whole way around my gastroc and soleus complex. Hopefully they don't have a chunky monkey like my gastroc is. And squeeze that gastroc. If I get an absence of plantar flexion, so you should get a little bit of plantar flexion by doing it. Toes should kind of go out. Wait a minute. That sounds like that might relate to a primitive reflex. What was that primitive reflex again in the foot that had the toes moving around? Achilles deep tendon reflex, good. Stephanie?
Babinski?
Babinski, yeah. Right? They're all deep tendon reflexes. Right? In this case, I'm going to squeeze the gastroc and see if the toes plantar flex. If I don't plantar flex, if I don't get any movement of the toes at all, that could mean I've torn my calf. That would be a bad thing. Right? I don't know if any of you ever seen anybody with a torn calf. I want to say, didn't LeBron do that a few seasons ago? I think he tore his calf up pretty bad.
That was Kobe.
Kobe, that's it. Thank you. I was one of them. I'm confused. Yeah, right. And like he can barely walk. He had to be in that boot, and there's no movement of that ankle at all. Right. So if you'd have grabbed a hold of Kobe's calf and squeezed it, that foot would have just sat there. There had been no reaction. Right. But for a normal person, if you squeeze that gastroc, say this is my foot kind of hanging down, you'll get a little bit of plantar flexion going on in that foot because the gastroc is a kind of big muscle. So it's a test for gastroc also tightness in kids that have that really a toe walking syndrome. If I squeeze that and I get no movement at all in that foot, I know that I've got a really, really tight gastroc and I'm going to be stretching them for a while and they're not going to like me. Kids don't like me anyway. So this is kind of looking at where I kind of get a hold of that gastroc. Yeah, you're squeezing the muscle belly, John. See in the picture? And so what should happen with a normal person is you get a little bit of plantar flexion that goes on. For one of like the kids that I treat that has really, really kind of that toe where they're walking the toes, if I squeeze this gastroc really just even a little bit, man, boing, their toes plantar flex like crazy. Because that heel cord is so tight that any movement up here squeezing this gastroc, their foot just plantar flexes like crazy. And so then I can come in and I can put my hand on that gastroc and dorsiflex that foot in order to get a nice steady stretch of that gastroc. And then the kids love it. It feels great. Everyone loves their gastroc stretched. We talked about true versus apparent leg length in the very, very kind of beginning of the semester, right? And I said that true leg length discrepancy is a problem with the bones, right? It's an actual true, meaning there's something going on with the bones themselves, whether the angles are off, the length of the bones are off, whatever it may be. And then an apparent leg length discrepancy is where you have some shift going on. It could be at the back, could be at the pelvis, where something's just not right. And it's more of a postural leg length discrepancy than it is a bony leg length discrepancy. And if you remember, the true leg length discrepancy goes from the ASISs, so the bones of the pelvis, down to those medial malleoli. The apparent goes from the belly button down the medial malleoli. And we will practice both of those because we want to see if anyone in our class has leg length discrepancy. So back to Diana's question. What are the board questions going to look like on these? So there are a couple things they could look like. Number one, they could look like where they'll say, you're testing a patient for bicipital tenosynovitis or tendonitis. And you have your choice. So let me bring up a whiteboard here real quick. Just so that I have this. So it might look something like this, where they'll say that you have your choice of two tests. You can either test, so we're looking for bicipital tendonitis or tenosynovitis. I'm going to write tendonitis because it's shorter. And then I totally spelled that wrong. and din I-T-I. Okay, I spelled it close enough. And it says you have a choice of Yorksons, or you have a choice of speeds. And maybe they'll give you two other ones that have nothing to do with it. This is where the numbers come into play, Diana. All right. So you have your choice here between Yorksons and speeds. And you want to rule in. So you want to confirm that a patient has bicipital tendonitis. Good, right? Yorksons is the better option. It has a high specificity, 0.86. What about speeds? What would you say about speeds?
It's good for ruling out.
What is it really?
Not really. It's pretty trash.
Yeah, it's pretty trash. Yeah. Right now, there aren't any other tests out there for ruling out, really. So it's kind of our last go-to. It's 0.63. Yeah, right. It's a little better than a 50-50 shot. That's it. Pretty trash is a good way of looking at that one, right? So that's one way they may get a question on the boards, right? The other thing they may just ask you straight up is they may say that, you know, you're testing for ACL damage. And they'll say, which of the following is the choice for an ACL damage of the knee? Anterior drawer test, posterior drawer test, lateral drawer, or medial drawer test. Well, I hope you guys would know that if you're testing for an ACL, it's the anterior drawer. I hope that you guys get that right. Yeah, right? Because it's in the name. You're pulling the knee anteriorly. That means it's testing the ACL. So that's a lot of what you're going to be looking like on the boards. They're not going to be specifically asking you to tell the difference between a Hawkins-Kennedy versus a empty can test, right? They literally are that easy for the most part, Diana. You know, they're not going to ask you, well, you know, or they may say, Diana, they may say that you have, yeah, it might describe how you do a test, right? It might be talking about that you have a patient and you're applying pressure over the medial epicondyle while they do resisted pronation and radial deviation. What are you testing for there? Well, if I'm putting pressure over the medial epicondyle, right? If I'm putting pressure over the medial epicondyle, what do you think I'm testing for? You don't even have to know the test. If I'm squeezing that medial epicondyle, I'm testing for what?
MCL?
Not MCL.
Epicondylitis.
Epicondylitis, yeah. I mean, pretty much if I'm squeezing anything, I'm testing for inflammation, right? If I come up here and press on that bicipital tendon and the patient goes, ow, that doesn't feel good, I'm testing to see if they have inflammation, right? So that'd be one where you're just like, oh, well, I'm testing for inflammation, right? Or it'll say something that you are performing Tinel's over the canal of Guillain out here. So you know that's a tapping test. What nerve are you testing for? So that's just an anatomy question, right? What goes through the canal of Guillain?
Ulnar.
Ulnar nerve, yeah, right? Or I'm testing Tinel's of the carpal tunnel. What nerve are we testing? Median nerve. I know I'm literally making these really seem easy, but it's not that they're going to ask you the difference again between an posterior apprehension and anterior apprehension test. They're going to ask you about an apprehension test, and you know that they're testing for instability of the shoulder, right? Seeing if the patient dislocates easily. So it's not that they're that difficult. They really aren't. I know I'm really making this kind of seem simple, but in reality, it pretty much is simple. They're not going to ask you to compare Roos versus Allen's versus Adson's, right? But they might say, which of the following is not a test for thoracic outlet? And so you have the Roos, you have the Allen, you have the Adson's, and then you have the Phelan's. Well, Phelan's is this. So that's not for thoracic outlet, that's for carpal tunnel syndrome. Yeah, right. It's not, these aren't designed to be difficult. It's more, do you understand what you're doing? That's why on that sheet that I gave you, that long 5-page sheet, I didn't tell you how to do the tests. I just told you what they're tested for. Same thing kind of on this PowerPoint. I didn't really go through the specifics. I mean, it has the specifics on how to do the tests, but it's more about just understanding what the test is looking at. And that is by far more important for a PTA, because who's going to pick which special tests we do?
The PT.
The PT, yeah. It's not our job to pick it, right? We don't go out and pick, oh, well, I've got Joe coming in for therapy today. Today, I think I'm going to do the Allen test with him. No. We're just going to duplicate whatever the PT's done in the eval. Or the PT may say, hey, you know what? I worked with Joe last week on his hip. And, do me a favor, try a scour test with him today and see if you get a positive result. Scours for hip labrum impingement. And do that for me and come back to me and let me know what you get. Well, yeah, that's within our scope of practice, right? That's just doing a test the PT told us to do. And that's where you go back and some of those, yeah, that's at least before, right? Some of these tests, even I if you asked me right now, if I'm going to look down through here and let me see, just pick a random one that I don't know. If you were to ask me what the Stork standing test was, I'd have no idea. I would have to actually go back to my book and see what it is. You do not have to remember the specificity and sensitivity. I put those on there so that you can, when you're doing those in the clinic, you can look at them and go, man, why are we kind of doing this? If there's specificity and sensitivity on your boards or on my test, I am going to give you the specificity and sensitivity. Those would be the ones where I say, which of the following is best for ruling it in or for ruling it out? And you're just going to have to look at the numbers. That makes sense? That puts you a little bit at ease, Anthony? That you don't have to memorize all those numbers?
Yeah, I feel better.
Yeah, because I'll be honest, you would be amazed how many books I had to go through to find all of those numbers, because they're not easy to find.
Appreciate it.
Because if they're not easy to find, then PTs never go, well, this is a garbage test, I shouldn't be doing it. I'm just saying, you'll be amazed at how many people do. You just saw right there with the speeds and the yorksons. Really, speeds is kind of how is it that Anthony put it? It's kind of trash, right? But we still do it in the clinic because we don't have a better test yet. Now, here's the exciting part. Amanda could come along and go, man, speeds test is kind of trash. And it's something I'm seeing in my clinic a lot. So let's get together. Let's get a bunch of patients with bicipital tenosynovitis, and let's try to find a test that's really good at ruling it out. And so, 6 months from now, when she's graduated and she's out there and she's working the field, not 6 months, I guess we got a little longer than that. Let's say 2 years from now, there may be a publication in PT Journal that shows the Hunley test for shoulder bicipital tenosynovitis. That's the good part about this, is you guys could all develop your own tests, and eventually somebody in you guys in school will be learning about those tests. That's the cool part to me. I don't know. What do you think, Amanda? You going to design that test?
I know. I was actually, that had a nice ring to it.
Yeah, right. The Hunley test.
So isn't that called something when it's anecdotal, research, where you're doing just the research inside the clinic? And we can suggest that. Do we have to have permits or like?
Well, no, not necessarily. At that point, you're doing more like case studies and small cohort studies is what that's called, right? Because you're just doing inside the clinic. And then what happens is hopefully you do that inside the clinic and you come up with this test, and then say Dr. Dr. Landers at UNLV says, man, did you see what Amanda was doing over in this clinic? Let's bring that over to UNLV where we do research, and let's bring that onto a big scale and see if her test is really solid, right? And then we do peer review, right? Because now you've got this big test going on, and there's a lot of people looking at it. Then, yeah, when you have a big test like that, that's going to be peer reviewed, published. Yeah, then we need to have kind of some specifics laid out, and got to go see the IRB and all those fun people. This is why I don't do research, because that's way too much crap. I'm just going to be honest. I don't know about you guys, but I don't want a PhD. All right. Any questions on the special test today?
Not yet.
Not yet? Good. All right. So tomorrow we're going to have class, right? Right. Yeah. And none of you are going to go in and bother Dr. Reskin in her office tomorrow, right?
Right.
Good. I will have the lecture up shortly. I will find you, Amanda says. So have a good rest of your day. I'm going to stop the recording.